Welcome to Pediatric Case Review. Today's lecture is a comprehensive, case-based review of Argininosuccinic Aciduria, also called ASA, prepared for general pediatricians. Argininosuccinic aciduria is a urea cycle disorder caused by deficiency of the enzyme argininosuccinate lyase. We will work through 14 carefully crafted clinical cases, covering the neonatal presentation, the enzyme defect, newborn screening, hyperammonemic crisis management, the systemic complications, contraindicated medications, genetics, characteristic clinical findings, the plasma amino acid profile, the role of arginine, the differential diagnosis, confirmatory testing, dialysis, and liver transplantation. Let us begin. Question 1. A 3-day-old male is admitted after progressive lethargy and poor feeding since day 2 of life. He is hypotonic and tachypneic, and he has no fever. Laboratory studies show ammonia of 320 micromoles per liter, which is markedly elevated. There is no metabolic acidosis and no ketonuria. What is the most likely diagnosis? Option A, Argininosuccinic aciduria. Option B, propionic acidemia. Option C, maple syrup urine disease. Option D, septic shock. Take a moment to consider the laboratory pattern before we reveal the answer. The correct answer is option A, Argininosuccinic aciduria. The key to this case is hyperammonemia occurring without metabolic acidosis and without ketosis. This combination strongly points to a urea cycle disorder rather than an organic acidemia, which typically causes acidosis and ketosis. Within the urea cycle disorders, an elevated arginosuccinic acid level is the distinguishing feature that confirms arginosuccinic aciduria, because this metabolite accumulates only in this specific condition. In a true crisis, ammonia may exceed 500 micromoles per liter, which represents a metabolic emergency requiring immediate intervention. Question 2. A 3-day-old neonate presents with lethargy, poor feeding, and rapidly rising ammonia. Plasma amino acids show markedly elevated argininosuccinate and low arginine. The urea cycle is blocked at step 4. Which enzyme is deficient? Option A, carbamoyl phosphate synthetase 1. Option B, ornithine transcarbamylase. Option C, argininosuccinate synthetase. Option D, argininosuccinate lyase. Consider which enzyme acts at the 4th step of the urea cycle. The correct answer is option D, argininosuccinate lyase. This enzyme catalyzes step 4 of the urea cycle, where it cleaves argininosuccinate into arginine and fumarate. When argininosuccinate lyase is deficient, argininosuccinate accumulates upstream. Arginine production fails, and ammonia rises because the cycle cannot proceed. The combination of high argininosuccinate and low arginine in this case is the classic biochemical signature of this enzyme block. The responsible gene is the ASL gene, located on chromosome 7, and the condition is inherited in an autosomal recessive pattern. Question 3. A 36-hour-old term neonate has a time-critical newborn screening alert from the state screening laboratory. Tandem mass spectrometry performed on a dried blood spot has flagged an abnormal result. The infant appears well, is feeding adequately, and has no symptoms yet. Which metabolite triggered the urgent newborn screening report? Option A, elevated ammonia. Option B, elevated argininosuccinic acid. Option C, elevated citrulline. Option D, elevated orotic acid. Think about which analyte the screening assay actually measures on the blood spot. The correct answer is option C, elevated citrulline. Newborn screening by tandem mass spectrometry detects elevated citrulline as the primary marker for argininosuccinic aciduria because citrulline accumulates proximal to the enzyme block. Argininosuccinic acid itself can serve as a detectable secondary marker that supports the diagnosis. Under the American College of Medical Genetics classification, this result is considered time-critical, meaning urgent follow-up testing and clinical evaluation are required. A useful distinction. In argininosuccinic aciduria, citrulline is moderately elevated, whereas in citrullinemia type 1, citrulline is very high, often above 1,000. Question 4. A 6-month-old known Argininosuccinic Aciduria patient presents with lethargy, vomiting, and poor feeding. Ammonia is 380 micromoles per liter. He is still breathing spontaneously. What is the most important immediate first step? Option A, start intravenous sodium benzoate immediately. Option B, order brain magnetic resonance imaging to assess cerebral edema. Option C, administer oral arginine supplementation. Option D, stop all oral feeds and establish intravenous access with high-dose dextrose. This is a time-critical scenario, so consider the very first action that addresses the underlying problem. The correct answer is option D. The single most important immediate step is to stop all oral feeds and oral medications and to establish intravenous access. Stopping protein intake removes the nitrogen load, and the patient is then placed on intravenous dextrose at 10% or higher with intralipid as needed to reverse catabolism and target a glucose of 120 to 170 milligrams per deciliter. Intravenous nitrogen scavengers, namely sodium benzoate and sodium phenylacetate, are given with a loading dose of 250 milligrams per kilogram. Intravenous arginine hydrochloride is added at a loading dose of 600 milligrams per kilogram. Time equals brain, so act within minutes. Question 5. A 7-year-old boy with known Argininosuccinic Aciduria has been on dietary protein restriction and oral sodium benzoate for 3 years. His ammonia levels have been consistently normal. At today's routine visit, his blood pressure reads 118/78 millimeters of mercury, and his abdomen shows hepatomegaly. These findings are most likely explained by which of the following? Option A, poor dietary compliance causing recurrent hyperammonemia. Option B, side effects of sodium benzoate therapy. Option C, comorbid essential hypertension unrelated to Argininosuccinic aciduria. Option D, intrinsic systemic complications of argininosuccinate lyase deficiency independent of ammonia control. The correct answer is option D, intrinsic systemic complications of argininosuccinate lyase deficiency. Argininosuccinic aciduria is more than a hyperammonemia disorder. Arginine is the substrate for nitric oxide production, so arginine deficiency leads to reduced nitric oxide and consequent hypertension. Hepatic disease, including hepatomegaly and fibrosis, is an intrinsic feature of the condition and is not driven by ammonia levels. This is why both hypertension and liver involvement can appear even in a patient whose ammonia has been consistently well controlled. Recognizing these complications means broad monitoring of blood pressure and liver function is essential in every patient. Question 6. A 4-year-old boy with known Argininosuccinic aciduria presents with febrile seizures during an acute illness. Which antiepileptic drug is strictly contraindicated in this patient? Option A, levetiracetam. Option B, phenobarbital. Option C, phenytoin. Option D, valproic acid. Think carefully about which of these agents directly interferes with the urea cycle. The correct answer is option D, valproic acid. Valproic acid inhibits carbamoyl phosphate synthetase 1, which is the first enzyme of the urea cycle. In any patient with a urea cycle disorder, this inhibition can precipitate life-threatening hyperammonia. The clinical rule is absolute. Never give valproic acid to a patient with any urea cycle disorder. Safer alternatives, such as levetiracetam, should be selected for seizure control in these children. This is a high-yield point that is frequently tested and, more importantly, frequently relevant at the bedside. Question 7. Healthy, unaffected parents have a newborn diagnosed with Argininosuccinic aciduria, confirmed by homozygous pathogenic variants in the ASL gene. They ask, what is the chance that their next child will be affected? Option A, 50% recurrence risk. Option B, 25% recurrence risk. Option C, no recurrence risk, sporadic mutation. Option D, 100% recurrence risk. Both parents are carriers. Consider the inheritance pattern of this condition when working out the recurrence risk. The correct answer is option B, a 25% recurrence risk. Argininosuccinic aciduria is inherited in an autosomal recessive pattern. Because the affected child carries 2 pathogenic variants, Both parents are obligate carriers who are heterozygous and asymptomatic. With each pregnancy, there is a 25% chance of an affected child, a 50% chance of a carrier child, and a 25% chance of an unaffected non-carrier child. These probabilities apply independently to every pregnancy. Carrier testing and genetic counseling are recommended for all family members. Question 8. A 5-year-old with known metabolic disease presents for routine follow-up. His mother reports that his hair breaks easily and looks dull. On close examination, you notice regularly spaced nodular swellings along each hair shaft. What is the name of this hair finding? Option A, pili torti. Option B, Manila-thrix. Option C, uncombable hair syndrome. Option D, trichorexis nodosa. Think about the characteristic hair abnormality associated with Argininosuccinic Aciduria. The correct answer is option A, trichorexis nodosa. Trichorexis nodosa is caused by arginine deficiency. Arginine is essential for normal keratin synthesis, and when it is lacking, the hair shafts become brittle and fragile, developing the characteristic nodular swellings seen on examination. This is a recognized clinical finding in Argininosuccinic Aciduria, and it is at least partially responsive to L-arginine supplementation. A useful clinical pearl. Trichorexis nodosa in any child should prompt the clinician to include a metabolic screen in the workup because it may be the visible clue to an underlying urea cycle disorder. Question 9. A 4-year-old boy with known Argininosuccinic Aciduria on stable treatment attends a routine metabolic follow-up. His plasma amino acid panel is drawn. Which pattern is most expected? Option A, low citrulline, elevated arginine, normal argininosuccinic acid. Option B, normal citrulline, normal arginine, normal argininosuccinic acid. Option C, elevated citrulline, elevated argininosuccinic acid, low arginine. Option D, low citrulline, low argininosuccinic acid, elevated phenylalanine. The correct answer is option C, elevated citrulline, elevated argininosuccinic acid, and low arginine. Citrulline is elevated because it accumulates proximal to the arginosuccinate lyase block. Arginosuccinic acid is elevated and is pathognomonic for this disorder because this metabolite builds up only when the lyase enzyme is deficient. Arginine is low because its production depends on the lyase reaction, which has failed. This characteristic triad of high citrulline, high arginosuccinic acid, and low arginine directly guides clinical management, including arginine supplementation and dietary protein titration. Question 10. A 4-month-old with Argininosuccinic Aciduria on sodium benzoate therapy has well-controlled ammonia levels. The parents ask, if his amino acids are already elevated, why does he need arginine supplements? Option A, to lower elevated citrulline levels. Option B, arginine is toxic and must be diluted. Option C, arginine becomes conditionally essential and supports nitric oxide synthesis and urea cycle flux. Option D, to prevent trichorexis nodosa only. Select the best answer that explains the physiological rationale. The correct answer is option C. In Argininosuccinic Aciduria, arginine becomes conditionally essential. Although several amino acids upstream of the block are elevated, the body cannot produce adequate arginine itself because the lyase reaction that normally generates arginine has failed. Supplementing arginine serves two purposes. First, it maintains urea cycle flux and helps the cycle clear nitrogen more effectively. Second, arginine is the substrate for nitric oxide synthesis, and adequate nitric oxide supports vasodilation and helps prevent hypertension. A useful clinical pearl is to target a plasma arginine of 50 to 150 micromoles per liter. Question 11. A 3-day-old neonate is flagged on newborn screening with markedly elevated citrulline. Importantly, no argininosuccinic acid is detected on the report. Which urea cycle disorder most likely explains this newborn screening result? Option A, Argininosuccinic Aciduria, that is, argininosuccinate lyase deficiency. Option B, ornithine transcarbamylase deficiency. Option C, carbamoyl phosphate synthetase 1 deficiency. Option D, citrullinemia type 1, that is, argininosuccinate synthetase deficiency. The correct answer is option D, citrullinemia type 1. Citrullinemia type 1 is caused by deficiency of argininosuccinate synthetase, which is step 3 of the urea cycle. In this condition, citrulline is markedly elevated, often above 1,000 micromoles per liter, because it accumulates immediately before the enzyme block. The key distinguishing feature in this case is that no argininosuccinate acid is detected. In argininosuccinate aciduria, the block is one step later, so argininosuccinate acid is present in both plasma and urine. The absence of argininosuccinate acid is therefore the diagnostic key that separates citrullinemia type 1 from argininosuccinate aciduria. Question 12. A 5-day-old infant was flagged on newborn screening with elevated citrulline. Plasma amino acids confirm elevated citrulline at 210 micromoles per liter, elevated argininosuccinic acid, and low arginine. Ammonia is now controlled. What is the best next step to confirm the diagnosis? Option A, liver biopsy for histopathology. Option B, red blood cell enzyme activity assay only. Option C, repeat plasma amino acids in 2 weeks. Option D, ASL gene sequencing and deletion or duplication analysis. The correct answer is option D, ASL gene sequencing with deletion and duplication analysis. Molecular genetic testing is the definitive confirmatory test. Sequencing of the ASL gene identifies the pathogenic variants responsible for the condition, and deletion or duplication analysis detects larger structural changes that sequencing alone may miss. An enzyme activity assay performed in red blood cells or in fibroblasts can also support the diagnosis, showing markedly reduced or absent activity. Beyond confirming the diagnosis in the patient, molecular testing also enables accurate family counseling and carrier detection for relatives. Question 13. A 3-day-old with known Argininosuccinic Aciduria is on intravenous sodium benzoate, sodium phenylacetate, and intravenous arginine. Ammonia is now 480 micromoles per liter and still rising despite this medical therapy. This is time critical. What is the next step? Option A, increase the sodium benzoate dose by 50%. Option B, start peritoneal dialysis immediately. Option C, initiate urgent hemodialysis. Option D, add oral sodium phenylbutyrate. Consider the most effective way to rapidly remove ammonia when medical therapy is failing. The correct answer is option C, initiate urgent hemodialysis. When ammonia is above 300 micromoles per liter and continues to rise despite maximal medical therapy, extracorporeal removal is required. Hemodialysis clears ammonia roughly 10 times faster than peritoneal dialysis, which makes it the preferred modality in a rapidly deteriorating patient. The child should be transferred to a pediatric intensive care unit, and escalation must not be delayed. Medical therapy alone is insufficient when ammonia is climbing quickly. Remember the principle that time equals brain, and escalate early. Question 14. A child with severe recurrent hyperammonemic crises undergoes liver transplantation. Which statement most accurately describes the expected outcome? Option A, it resolves both hyperammonemia and all neurological complications permanently. Option B, it corrects the enzyme defect in brain tissue, preventing cognitive decline. Option C, it eliminates the need for any further arginine supplementation after transplant. Option D, it corrects hepatic argininosuccinate lyase deficiency and reduces hyperammonemia, but it does not prevent neurological complications. Select the most accurate statement. The correct answer is option D. Liver transplantation restores hepatic argininosuccinate lyase activity, which resolves or greatly reduces the hyperammonemic crises. However, argininosuccinate lyase is also expressed in the brain, and the transplant does not correct this. As a result, neurological, cognitive, and behavioral complications can persist after transplantation. It is important to counsel families clearly that liver transplantation is not a complete cure. In addition, because the brain still depends on circulating arginine supplementation must generally continue even after a successful transplant. Before we conclude, I want to tell you about our community on Patreon, named Pediatric Case Review. This community brings together all of our videos, arranged neatly by system, so you can access every lecture in one organized place. In addition, all of the presentations used in the videos are available as images, so you can read, review, and practice every question at your own pace. If you would like the details and want to know how to subscribe, please leave a comment below this post, and we will message you directly with everything you need. Let us summarize the key takeaways. First, think of a urea cycle disorder early. Hyperammonemia without acidosis and without ketosis points to the urea cycle. Second, the combination of elevated citrulline and elevated argininosuccinic acid on plasma amino acids confirms the diagnosis. Third, in a crisis, time equals brain. Stop feeds, start intravenous dextrose, and give nitrogen scavengers immediately. Fourth, escalate to hemodialysis early when ammonia exceeds 300 or keeps rising. Fifth, hypertension is intrinsic, driven by arginine and nitric oxide deficiency. Sixth, never give valproic acid in any urea cycle disorder. And seventh, liver transplant is not a cure because neurological disease persists. Thank you very much for joining me through this case-based review of Argininosuccinic Aciduria. If you found this lecture helpful, please follow the channel for more informative case-based presentations across pediatrics. If you have any questions about today's topic or suggestions for future lectures, please leave them in the comments, and I will be glad to respond. Remember that this presentation is intended for educational purposes and does not replace professional clinical judgment or current institutional protocols. Wishing you all the best in your practice. I look forward to seeing you in the next case review.